Hi, we want to thank you for attending our Tuesday at just past 5 p.m. presentation today on the new Healthcare Price Transparency Bill. This is Alan Gassman. I'm a lawyer in Clearwater, Florida, and I'm pleased to have as my guests today and the real experts, Dr. Pariksith Singh from Access Healthcare and Lester Perling, a healthcare lawyer from Fort Lauderdale. Lester and Dr. Singh, I want to welcome you, and are you both with us and able to hear and talk?
Yes. Hi, everyone. This is Dr. Singh.
Hi, I'm here. This is Lester Perling.
Super. Well, Dr. Singh, you really were ahead of the curve when it came to complying with this law. In fact, one of our PowerPoints is a sample of your 15 square foot disclosure. Do you want to go ahead and give us a little bit of an introduction here?
Yeah, I confess to you, Alan, that this law I found out about 2 days prior to its being effective, which was, I think, the 29th of June. And the moment I found out and I read about it with my limited legal knowledge, I was flabbergasted because it has put a tremendous onus on all primary care physicians. Essentially, it was made for urgent care centers, but it's very difficult the way it's worded to really differentiate between an urgent care center and a clinic that takes any walk-in or any patient who has a problem who is seen the same day or even the next day. It's confusing. So we took the conservative approach. We got 50 of our procedures together and the value that the price that we charge for it, and almost in a emergent setting, we got them printed right away, and we put them up in our lobbies. And then I realized that other physicians didn't know about it because I think this information will seep through. And Alan has done a great job putting this together so fast because if not followed and if somebody is found guilty of violating this, theoretically there's a penalty of $1,000 a day for this bill, and it's really puts a lot. It can be onerous. The good news about it is it sharpens our brain and makes us fix our prices, train our staff, and just like the other bill that was passed about controlled substances, which is also, I believe, effective July 1, this bill also has some good features. There's a silver lining to this cloud, and the silver lining is you are forced to become more compliant with the way you treat your self-pay patients and how you charge them, and it's probably the right thing to do to let the patients know upfront what you're going to charge. Having said that, the legal intricacies are many, and now I pass the baton to Alan and Lester to wade through that for us.
Okay, before accepting the baton, though, I do have one question. Are you getting any feedback from the office staff, the receptionist, as to whether patients who are coming in for Medicare or insurance and typical reimbursement are having any issues or heartburn over seeing this chart?
No, we have not seen that. Now, this is the 12th day. We put it up on the 30th of June at 5 o'clock, so it's been almost more than a week. And, patients haven't really complained. This was a big fear that patients would look at the prices and start having heartburn. We have to, by law, post prices for codes that are either at the same price as Medicare rates or higher. We cannot charge lower than the Medicare rates. But nobody till now has had any heartburn over it. Now, a lot depends on how you communicate with patients. When they ask you, you have to communicate with them, and it's all about how you treat people and how you explain to them. So in that sense, we have had our staff trained for these things for a long time. This is the first time we posted our stuff, but we've been very focused on compliance and customer service all these years. So it has not been a big hiccup for us. But I can understand for practices that are new to the concepts of compliance and customer service and all that, the newfangled stuff in medicine, they may have a little hard time. But again, this challenge can be taken as an opportunity. No patient has had a complaint about this yet.
Okay, that's good to hear. Okay, so Lester, if you can help me, that's Lester, prepared a nice PowerPoint. It's about 14 pages long, But I tried to get this summarized onto one page, and I thought it would help the viewers to just try to look at this one page. This is page 2 of the PowerPoint, and to try to get most of the vocabulary and some of the classifications that we're going to talk about here. So on the top left-hand side, I have this concept or this definition of an urgent care facility. And the definition is below it. This is a clinic or a facility that provides immediate ambulatory medical care to patients with or without an appointment, which I think means that if I hurt my finger and I call a doctor and I say, you know, I hurt my finger and I need some immediate care, I need somebody to put a big Band-Aid on it, that would be immediate ambulatory medical care. Lester, is that correct?
I think it is. I think that may be one of the sort of almost easier examples. This definition is so broad, and when one thinks of an urgent care center, I think you don't normally think of appointments, but nonetheless, the statute includes with an appointment in the definition. And so, you know, that may mean that if I cut my finger and I call my doctor's office and say I've cut my finger and I need a Band-Aid, and they say, well, why don't you come in in a couple of hours, come in at 2 o'clock this afternoon, is that an immediate appointment? I asked the question, but I certainly don't know the answer because there really is no guidance in the statute, and certainly none anywhere else that talks about what my immediate appointment might be. So some things are clearly, you know, urgent care centers. You know, I can just walk in and say, here I am, I have a fever, please check me out. I mean, that's what we all think of as an urgent care center. But what about my internist's office, who I might call and say, I've got 104 fever, and they say, come in at 3 o'clock this afternoon? Does that turn my primary care physician's office into an urgent care center? And the statute seems like it might.
Yeah, so I mean, there was a medical specialty practice near my office that had a little sign that said, walk-ins welcome, and that sign's gone now. Now, I'm going to go down to the bottom of the chart on the left-hand side to the definition, to something special about primary care providers, which gives us a better hint about what the statute's intended to do. And this says that MDs, DOs, and advanced registered nurse practitioners and PAs who commonly treat patients without a referral, so this would be the primary care providers, are not required to comply unless they take patients without appointments. So I guess my own internist or my own primary care doctor, if I call and say, I hurt my finger, I know I need at least a Band-Aid, when can he see me? And they say, well, you can't just walk right in. He can see you in 1.6 hours at exactly 10:50 a.m. Then I would think that my primary care doctor is going to be exempt from this law and is going to have to train his front desk or her front desk not to let anyone come in without an appointment if they really, really don't want to post this list. Does that sound correct, Lester?
I'm taking a quick look. I was taking a quick look at the bill as you were speaking, and I don't think it's right that there's a different definition with regard to primary care doctors and that it has to be without an appointment. I think that if the primary care doctor provides immediate appointments, then there would still fall within the definition of urgent care center, because it's really not an exception for primary care doctors. There is an incentive to primary care doctors who may not otherwise be an urgent care center and have to comply with the requirements, but if they do comply, the statute does, as noted in your box down here, that they get their medical license fee renewal fee waived for a year, and they're exempt from continuing education requirements for a single 2-year period. But I still think that the regular urgent care center definition applies to them as well.
Okay, I'll recheck that then. Okay, then just a couple of other things I wanted to cover here. There is a concept that everyone listening to this should understand, and that is under Florida statutes, when you have a medical practice or a healthcare clinic owned by non-physicians who are not related to the physician, that clinic has to register with the state. And there's a registration fee, there's fingerprinting of the owners, there's a possible location review, and a lot of the urgent care centers and a lot of the medical practices nowadays are not physician-owned, or they have a non-physician owner other than a relative of a physician, and therefore they have had to register as a clinic with Tallahassee. All of those entities have to comply with this rule. Also, there's a kind of a silly concept, which is that if you are doctor-owned, or you're owned by a doctor and his family or her family, and you don't need to be a licensed healthcare clinic, you can apply to get an exemption certificate that proves that you don't have to be a healthcare clinic. And some of the health insurance plans are requiring that doctors get this exemption certificate. And if you order this exemption certificate after June 30th, 2011, then even though you would have been exempt from this rule, then you're no longer going to be exempt from this rule. Is that correct, Lester?
It is, and there's a question with regard to, well, what if I'm a physician's office, I request a certificate of exemption after July 1st, it's now after July 1st, but I don't fit the definition of urgent care facility. Do I still have to comply and post my prices? And I don't know the answer to that because the statute really doesn't address it. So the implication of getting the certificate is not really clear based on the language of the statute. Arguably, unless I'm an urgent care facility, I don't need to comply, even though I did get the certificate of exemption from healthcare clinic licensure. I mean, it essentially makes no sense in the statute. I guess.
Yeah, I read the statute. Yeah, I read the statute 3 times this weekend, and came away just confused and humiliated. It is a very, poorly drafted statute. It will hopefully be corrected within a matter of months after all the different interest groups and lobbyists have had their bite at an apple. But it clearly is pointed towards getting anyone who would compete with an urgent care center or who would provide medical care to somebody without insurance to post that list. Now, whether this was a 3 a.m. drafting situation and they left some words in and took some words out, I don't know. But, Lester, let me let you get to your PowerPoints now that hopefully the audience has a pretty good idea of what the primary definitions are that we're going to be talking about.
All right, and feel free to jump in when I confuse you, which probably will be right off the bat. The summary there is pretty straightforward. The governor signed the bill on June 2nd, and it became effective as of July 1. There was no lead time for implementation. The bill here, it says it provides an incentive to post prices. I guess the incentive is if you post the price and you're required to, you don't get fined $1,000 a day, which I suppose is a pretty good incentive. We'll talk about a little bit in more specifics the primary care incentive in a moment. Specifically, what the bill requires is that if you fit within the definition of urgent care, you have to post the most frequently used charges. So that means to the extent that you're in a position to have to comply with this statute, you have to be aware of what those 50 most frequently used charges are. Probably these days, most practices, that's fairly easy to pull out of their software. Maybe for some smaller ones, it may not be so easy, but that's the requirement. If you're a healthcare clinic, a licensed healthcare clinic, the medical director of that healthcare clinic is the one who's legally obligated to ensure compliance. So theoretically, if a physician is a medical director of a licensed healthcare clinic and doesn't ensure compliance, that physician could be disciplined for failing to fulfill that statutory obligation. So it, like many statutes, this statute also poses a sort of a trap for the unwary physician who agrees to be a medical director of a healthcare clinic. Part of this bill is in what has been a long-standing statute, which is called the Patient's Bill of Rights and Responsibilities. Is actually a group of laws, and that statute was pretty straightforward. It obligated certain standards of care and the right to get an estimate of the cost of their care, to get an itemized bill, things like that. But there was no statutory requirement about posting prices prior to this. So this bill changes that. The law now defines what a primary care physician is, at least for purposes of the incentives to primary care physicians to publish. And Alan talked about that. It's a physician who primarily provides medical services to patients commonly referred without, which are commonly seen without a referral from another provider. And examples would be pediatricians, family practice, and internists. Now, a primary care physician who's not otherwise obligated to post because their office is an urgent care center as defined, as I mentioned, may do so voluntarily. And if they do so, then they get certain benefits. Now, before we get to that, although the slide is called primary care providers, the requirements here really apply to everybody who's posting. As I mentioned, it has to be the 50 most frequently performed services. The charges have to be what would be charged to an uninsured patient if they're paying by cash, check, credit card, or debit card. So if a practice, for example, has multiple different charge lists, charge masters, and they might charge a cash-paying patient less than they charge everyone else because they don't have to collect the bill, they save, obviously, there's some administrative costs, that's the price that has to be posted, not the amount they might charge to Medicare or to some other third-party payer. The schedule has to be posted in a conspicuous location, meaning it needs to be someplace fairly obvious, and it needs to be at least 15 square feet in size. And if the patient requests an estimate, then the estimate needs to be consistent with the charges that are posted. Now, getting back to primary care providers, if the primary care provider chooses to post voluntarily, then they are exempt from their license renewal fee for 1 2-year renewal period. And interestingly, they're exempt from the continuing medical education requirement for a single 2-year period. That's on a personal note, that kind of struck me as funny, that I guess if you post your prices, you don't need to remain current with regard to the practice of medicine. But anyway, that's what the legislature decided is the trade-off. However, what they give, they can also take away, because if the primary care physician chooses to publish and takes advantage of those incentives, but then they change their mind. Were you going to say something, Alan?
No.
Oh, I thought you heard me.
Sorry.
And they don't keep the prices up, then the physician must pay the exempt amount of the license fee and make up any continuing medical education credits that were waived. So while there's an incentive to opt in, if you don't otherwise have to, the legislature also created a disincentive from opting out. The statute doesn't say how long, though, you have to comply. So does that mean that, let's say you have your prices up for a year and then you decide not to do it anymore? Have you had them up long enough, or do you still have to repay the, or not repay, but pay the waived license fee and make up the continuing education credits? Or is it a 2-year cycle, like the licensure renewal? The statute just doesn't say how long you have to voluntarily comply. We talked, I think, about the definition of an urgent care center. We won't go into that. Again, the key point is the use of the word with an appointment. And I think that's where the problems could come into play. You know, without an appointment, so that people are walking in, is fairly straightforward. But then there's the question of the immediate ambulatory appointment. Here's the urgent care center requirements. They're really essentially the same as we went over with the primary care physicians. You'll note that the grouping can be in 3 different groups, so you can have 3 price levels. So you can take the 50 procedures and divide them into 3 different price levels if you choose to do so. I'm not sure exactly what that gets you or how that's going to be different. I suppose it allows you to post 3 different signs as opposed to 1 sign and break them up by high price, mid price, and low price. It may mean that you can group all your procedures by price level and then post a total of 50, some number from each group. Again, the statute really just doesn't say what it means by the option to post in 3 price levels. So the bottom line is there, I just don't know. As Dr. Singh mentioned, the penalty is $1,000 per day. If the government were to find that you should have posted it, but you didn't. One point I want to make here that's not in a slide because it's a little bit too complicated to put in a slide, but probably is important to know. There's an enforcement issue, and that the state enforcement agencies recognize the requirements that do not relate to a licensed healthcare clinic are located in Chapter 395. Chapter 395 happens to be the section of the Florida statute that regulates hospitals, ambulatory surgery centers, and a couple of other specific types of healthcare providers. It is not the section of the statute of the Florida statutes that regulate physicians. The Department of Health, which regulates physicians who are licensed under either Chapter 458, 459, 460 for podiatrists, depending upon the type of license, doesn't have authority to enforce Chapter 395. So although the obligation on the physicians is in 395, the Department of Health has no authority to enforce 395. So I've talked to a couple of people at the Department of Health about that, and they're not quite sure what to do with that yet. But that's going to present an interesting challenge to them and may in fact delay enforcement if they otherwise were inclined to do so, simply because they may have some legal impediments to actually enforcing this requirement. They do have the power to discipline a physician for not complying with any statutory requirement. That might be the way they're going to do it. But right now, at least as the Department of Health is thinking about it, they're not too sure. It's the Agency for Healthcare Administration that has the authority to enforce this against healthcare clinics or to entities that receive a certificate of exemption, maybe. However, if you have a certificate of exemption, it means you're exempt from Chapter 400. So the Agency for Healthcare Administration told me they're not sure they could enforce this statute against entities that get a certificate of exemption, because the very fact that they have the exemption means they're exempt from that whole statutory scheme. So as Alan mentioned, I think the statute, and I hope there's no legislators listening, I think it was drafted during some drunken party at 3 o'clock in the morning, because it just is not thought through even, almost at all. It has so many holes in it as to be ridiculous. But nonetheless,
it's usually much better drafted than this. It's embarrassing as a lawyer to even read this statute, to think that somebody drafted the statute.
That's for
and
sure.
did not invite me to the party.
And they should have.
Right.
Now that doesn't mean you shouldn't comply, because you should, because state agencies are pretty adept at finding ways to enforce laws that might be questionable. It might provide some degree of a defensive argument, but you really don't want to be in that position. And And as Dr. Singh mentioned, providing this type of information to patients who are in fact consumers and in fact the customer of the physician's practice is not a bad idea, so that to the extent that they're coming in for some sort of elective service, they don't, particularly when they don't have insurance that's going to cover it, they know what they're getting into, much like if you go to Publix and buy some groceries.
Lester, can the sign prominently say these prices do not necessarily apply to Medicare and patients with insurance to help avoid the confusion there?
Yeah, the statute doesn't address it, but I think, Alan, that's a good idea. I would say that the posted prices are for cash-paying patients. There may be different prices for services paid for by, covered by third-party payers, something like that. Because otherwise that could cause some confusion, because when patients see that their insurance company was charged $50 and they happen to take a picture of that price list with their cell phone, and on the price list it says $40, I can see some ensuing problems.
Right, right. Okay. So should we go to page 18? Because I see on page 18 something about prescribing. Controlled substances. Oh, I see. You're comparing it to the controlled substance rules.
Yeah, really, these were some of Dr. Singh's thoughts.
Okay.
Maybe he wants to sort of address some of these recommendations at the end.
Okay, Dr. Singh, I'm going to go to slide 22, which is your sample pricing list, and turn this back over to you to bring some sanity back to it here.
I'm not sure I can bring sanity to a bill that's poorly drafted, but the thought behind it may not have been so strange after all. I mean, as Lester said, it's good to share this information with patients. It's good for our staff to know what we will charge. It is good to make everybody compliant. What in the past I've seen some practices coming as a part of our IPA, and if it's a self-pay patient, they feel like charging whatever they do professional courtesies, they write off payments, or they'll say, okay, just pay me this much. So there's no system, and apparently Medicare frowns upon it. I mean, this is write-off and courtesy discounts are an absolute no-no. So I think we should use this as an opportunity to learn that we need to fix our prices. We need to look at every practice as a business. Yes, a physician practices in a very different world, and you can't tie them up with all these rules. But as you know, it's a business. We have to follow these rules, and these are very important rules. So it's not like a person comes for a Botox and I charge them $500, and the next person comes and says, I can pay only $300, and you charge them $300. Some practices do that, and that's not correct. It's not compliant behavior. And some practices charge less than Medicare for that particular code, and that is not right behavior. So I think the good thing that will come out of it is if physicians understand it and they put the right prices and they make sure they have at least somebody, a biller or somebody with that understanding evaluate it, then making sure that, say, 99201, if the price is $44, make sure that Medicare payment is not $46, because Medicare will ask you for money back if they realize that you are doing this. Because then, Lester can tell us better about it, but that's Medicare essentially looks at it as if they are discounting your practice so that you can charge others less. The other issue about CMEs, yes, you can probably get away without doing 2 years of CMEs. My recommendation is go ahead and do your CMEs. That's just good medicine. And I don't know how the department, when you get your license, how it looks. There's no clarity about certain classes, certain CME credits we have to get on, say, drug abuse or hospice care and pain management and malpractice issues. There are some required domestic abuse and HIV, And there's no clarity on it, at least to me. I would recommend people do their 40 CMEs and make sure they have all their mandatory CME credits. This is something that physicians need to learn from other kinds of professional businesses, say dentists. If I go to a dentist and they want to do a procedure, they will make sure they show me the pricing. They make sure that I sign it before they will do the procedure, because we don't realize we will often do a procedure and it may be an expensive procedure, and while the patient is checking out, they can argue with it that you did not tell me, there was no full disclosure that you're going to charge me this much, and then it creates a problem. Even if you can get the money out of them or you send them to collections and all that, that creates unnecessary aggravation. So the good thing is, if you communicate with the patient beforehand, I can guarantee you that almost 99% of them will pay when they're checking out if you have made a clean disclosure to them about the cost of the procedure. I don't understand the 3 price levels that Lester had talked about. I guess somebody who has put that in doesn't really know how a practice works. I don't understand what that price level means, so I would recommend we don't even pay attention to it. We make a standard for every code. This is what we charge, and enforce it and make sure everybody is held accountable to it. Your front staff is held accountable to it, and patients are held accountable to it, and physicians are held accountable to it, which means you're going to hold yourself accountable to it. And yes, you want to help people who are indigent and all, but then there are other ways to get around it. If somebody is truly indigent and can't afford it, then I believe you have to have a policy and procedure for indigent care, and they have to fill up certain forms in which, and only then can you discount a certain fee. And I'm afraid to even say the word discount. But in essence, I think this list is what we have done. Now, every practice will have its own charges. There are some physicians who will charge twice what we charge. There are some physicians who will charge less than what we charge. Some physicians will do other procedures. Just take a look. If you like some of our pricing, you can use it. You will have to just run your biller's software to see which procedures you're doing the most and make your own list. But I suspect most primary care physicians will be using these procedures, and probably 90% of the procedures will be shared. Otherwise, I think despite all its limitations, this is probably going to be something that will force us into a new realm of compliance, just like the controlled medication bill. And in some ways, we just have to take it as it is and take advantage of it and turn it to the best use possible. And what is that saying, Alan? You turn lemons into lemonade, or use lemons to make lemonade. Well, this is the chance to use this and make our practices more compliant and more patient-friendly.
I agree. I think that's excellent. Lester, any final comments?
No, I think Dr. Singh makes some good points. It's I guess one has to view it as another opportunity.
I think there's a good chance this statute will be fixed in the next few months, and a good chance that some of the government agencies are going to announce that they're not going to be looking at compliance for a while. I think that a lot of lobbyists are going to make a lot of money, and a lot of people are just going to have this chart on the wall, which is going to interfere with the decorations and the color effect. But unfortunately, that's just another small cost of doing business the right way. Okay, I want to thank Lester Perling and Dr. Singh for all of their support of these webinars. We're always looking for the next topic, but hopefully the next topic will be less complicated and less confusing. Have a great evening, and we wish you the best.